Morning, good night. It is great to see so many familiar faces and names here. For those of you who I haven't had a chance to get lucky enough to virtually see, my name is Jack. I use he, him pronouns, and I'm one of the CP Solvers team members. And yeah, it's good to be back on a Wednesday. I think amidst the sadness and the loss of the last couple of weeks, there's something very comforting about being here in this space, period, but especially with all of you. We are going to do a remixed edition of our usual Wednesday VMR. So I was saying I am sad to be flying solo today without a co-pilot Charmise, but I was saying we'll still do our best to land the plane together. Before we get rolling, we will need a case. So if anyone has a case that they would like to present, please do volunteer. See some heads turning and faces moving as though they're excited about something. So I'm gonna hold the tension and look. Looking for a case. And I should say too, there's a chance that at some point during this, I may have to go off camera for a couple seconds. I'm waiting for a phone call from a consultant, but we will just get to be solving multiple problems together. Oh, there we go, Promise. Excellent. Promise, you are the winner chicken dinner for presenting a case today. Promise, do you mind unmuting and introducing yourself to those of us who are to people here who haven't had the pleasure of getting to meet you before, and then we can go ahead and get started.
Hi, everyone. Yeah, I will turn on the camera in a sec. I just came back from the OR. I finished my last day of OB-GYN, so a little clue to the case. Let me see. Should someone pull up the board and then I can start presenting? So the chief complaint is frequent urination.
All right. Do you want to pause there, Promise, or you want to give us a little bit more? I trust you implicitly, so you let us know.
I'll pause here.
All right. So frequent urination. This is I would say as somebody who practices in the emergency room and urgent care clinic a lot of the time, it's something that we see quite often. And I will say my reflexive approach is different than the deliberate approach that I'm going to find myself probably taking here, acknowledging that we're in the case report discussion space. But I think from a sort of intuitive, non-analytic reasoning perspective, frequent urination, I most often equate to the most common scenario when we see it, which is going to be dysuria or symptoms of cystitis, right? And if you were to take all comers who have the report of frequent urination, that is probably the most likely underlying pathophysiology, is that there is irritation of the bladder, the urethra, or both, and that's causing some increased spasm, but also changes in the normal sensation down there. Many times those changes in sensation our brain equates to having the urge to urinate, and so we end up urinating quite frequently, right? So really inflammation anywhere in the lower urinary tract, and particularly in the bladder, is going to be one way that we can think about frequent urination, right? So that's going to be a problem with essentially the wall of the lining of the lower urinary tract. We can also have problems with the muscles that line the lower urinary tract, particularly the detrusor muscle of the bladder. And if that detrusor muscle is overactive for any reason, we can also see frequent urination, right? So this may be individuals who have, for example, experienced episodes of incontinence, particularly urge incontinence. This is where the actual muscle itself is overactive. And in the absence of inflammation, there is still frequent urination. And both of those first two findings focus on the actual pipes or the pumps that the urine is moving through, right? Those pipes and pumps can be inflamed, like with urinary tract infections, or just overactive, like we can see with urge incontinence. But there's also another important variable when we think about urination, and that's just the amount of urine that someone is making, right? So if we think about things that could cause a high volume of urine to be made, there's a few different mechanisms that we can think about. One of them is that there is the presence of something that has a large amount of osms making its way into the urine. The most common thing we see is people who have glucoseuria or diabetes, right? The high amounts of glucose in the bloodstream end up spilling over and leading to high amounts of glucose in the urine. And that high amount of glucose in the urine pulls a ton of water in it, right? So you may see urinary frequency in the setting of things like hyperglycemia. There's other rare things that can sometimes give people frequent urination, particularly in the healthcare setting. And those are usually things that we do to individuals. For example, a contrast load can make somebody urinate a lot right after they've gotten a lot of contrast. Certain medications that we give, like IVIG or mannitol, can also cause frequent urination. But that's usually in the setting of a known healthcare problem, right? So if we're thinking about something that can cause a high amount of urine volume to be produced, one of them is going to be high osmolar load, and the most common acquired cause of that, rather than iatrogenic cause, is going to be something like high glucose levels. There's a couple other things, though, right? You don't necessarily need a large osmolar load to urinate frequently. You could also just be taking in a lot of water. So polydipsia is another reason that somebody can have frequent urination. And then there's also the possibility that the kidney is actually having a hard time reabsorbing water, right? Normally our kidneys are trying to strike some balance between making urine and also retaining and holding on to water, right? And the name for this, or the disease that we call this, is just diabetes insipidus, right? Individuals who have diabetes insipidus are going to be losing free water and probably also drinking a lot if their thirst mechanism is intact, and that can also cause frequent urination. So if we zoom back out and look at that overall framework, we can ask ourselves, is this a problem with the volume or the tubing in which urine is flowing? Tubing problems can be inflammatory in nature, urethritis, cystitis, or just a urinary tract infection, or the system and through which it's flowing can also just be overactive, like an overactive bladder and detrusor muscle hyperactivity. Right? So that's the tubing and the pipes. And then there's a volume problem, which could be from things, again, related to a hyperosmolar state, like high glucose levels, things like a primary polydipsia or taking in a large volume, or problems with the kidney actually being able to concentrate urine well, which is something like diabetes insipidus. That's the sort of more analytic way that we can think about it. But reflexively, we're going to look for cystitis. And if that falls through, we'll go through the rest of that list together. I promise I'll turn it over to you. I got to talk to one of our colleagues here real quick, but I promise I will also catch up with the case. But go ahead and take us forward.
Okay, so this is a 60-year-old woman who presented to clinic, and she said that she has been struggling with frequent urination and also leaking for 4 years, and she leaks all the time. She is using daily pads, and then now she uses paper towel because it's more convenient for changes. She is a owner of a restaurant in an industry, and because she can't really take a lot of breaks, she only urinate every 4 hours each day, but she's noticing a lot of urination at night. And then she also said that she's unclear when she leaks, doesn't really notice any kind of leakage when she's moving or sitting. It just leaks. Let's see, and then I'll just go further into more history list. Okay, so she said she has tried a pessary a couple years ago, unclear if it helped, and so she stopped after a short trial. And she has a history of low back pain, has had some injections. She denies any vaginal bleeding, hematuria, or bulge, and she's not currently sexually active. She's postmenopausal, and she said that she has some pressure in the lower abdomen, some pressure in the pelvic area. She has some loose stools that's beyond her control. And sometimes there's a sense of urgency and having to rush to the bathroom. Also, sometimes having leakage with that sense of urgency. And then she also said that there are a couple of times that she remember having leakage with coughing or sneezing.
Awesome. Promise. In the interest of time, why don't you take us through all the background info and then also the physical exam here?
Okay. Yeah, for past medical history, she just has a herniated disc, hypothyroidism, surgical history, C-section 2 times, and then she's, let's see, like social history, pretty much non-contributory. She's postmenopausal, and that's pretty much all relevant there. And then, did you want exam findings too?
Yeah, that'd be wonderful.
Okay. So for physical exams, vitals, temperature, everything is normal. Of note, her BMI is 30. And let me read. Okay, so specifically with the GU exam, there's the external genitalia is normal, and her vulva is without lesions, erythema, or tenderness. There's appropriate sensation. The external urethral meatus and posterior perineum are without any lesion, erythema, or discharge. It's non-tender. The speculum exam is visualized and there's no lesion. It's pretty much all normal. Bimanual is also normal. That's pretty much it. And then everything else is normal.
All right, wonderful. I'm just getting caught up here on some of the background information. You know, rather than dragging you all through me catching up, I see some wonderful conversations in the chat. So I think I'm gonna pivot a little bit into the student VMR setting and just see what types of things we can curate from the crowd here. Nanda, are you in a place where you're able to unmute? I appreciate your suggestion so much about the possibility of a cystocele here, and I would love to hear more about what you're thinking.
Yes, I can talk. Nice to meet you, everyone. This is my first meeting here.
Welcome.
Thanks.
Where are you joining from?
Actually, I'm currently in Brantford in Connecticut.
Awesome.
But I'm from Brazil.
Well, thank you for being here.
Yeah.
You got a shout out from Amanda there.
I was thinking about like cystocele because it's a very common cause of in older women who particularly had many vaginal labor and postmenopausal as well, because that area get a little weakened after menopause. So I was thinking about this hypothesis.
I love it. Go ahead.
Yeah, also genital urinary syndrome is very common with postmenopausal patients.
I see. And for those, for people here who may not have heard about a cystocele before, could you share a little bit about what exactly it is, or anything else that you know about it?
It's basically like the bladder is compressing against the vaginal wall, and that causes some of the symptoms of sometimes difficulty holding inside urine. And yeah, I'm not sure about if I'm being very nuanced and with a lot of details, but it's basically that. If anyone have any questions.
Thank you so much, Nana. That is incredibly helpful. I think I appreciate both you sharing about this specific diagnosis in general, but also the fact that you're bringing us into thinking about some of the different anatomical factors that may not be visible on exam here. Because I think if we fall back on that original framework that we were talking about, I think you've localized is so helpful into thinking about it's the lower urinary tract we don't necessarily have symptoms that suggest underlying inflammation. And there's not a super strong history, both in terms of her background information, right? We don't see a past medical history of diabetes. We don't see historical evidence of things like high levels of urine intake, right? The diabetes insipidus hypothesis will have to come from the labs ultimately, but we have such a strong case given the recent menopause, as you highlighted, these prior episodes that have been or these prior vaginal deliveries, potentially putting her at risk for different anatomic changes, that if we go back to that original framework, right, we're localizing into the sort of non-inflammatory tubes and pumps element of the system, which certainly sounds like both in terms of a cystocele or other possible muscular mechanisms ends up being very important here. And I saw that Shema brought up the brilliant point in the chat of saying, like, you know what, we'll get the basic labs here, but we're probably going to have a very low threshold for urodynamic studies to just understand if there's incomplete voiding that could lead to the ongoing sensation of needing to go to the bathroom, or if there's any other anatomical abnormalities that could be contributing to these very frequent episodes of urination. This is fantastic. All right, Promise, take us forward here.
Okay, so since this is like an office visit, we didn't really do any CBC or CMP. We did a urine dipstick, which is positive for blood. And then we also did a post-void trial, and the PVR is 20. Her empty supine stress test is negative.
Ooh, Promise, I am finding myself out of my zone of comfort in many elements of this case, practicing at things that I don't see. What is that post-supine test that you mentioned?
That's a test where the patient lies on the bed, and then you kind of ask them to cough, and then it's very sensitive for diagnosing stress urinary incontinence.
I see.
And so if they leak with coughing, then you can say that they have stress urinary incontinence.
They leak with coughing. I see. Okay, that makes sense. This is awesome. I'm learning so much here. I also see a question in the chat about a post-void residual. I can translate that into saying that it is a scan of the bladder to look for any remaining urine in the bladder after someone urinates. Most of us will have a small amount of urine there, sort of in the single to double digit cc's. But if you start to see several hundred cc's of bladder or of urine remaining in the bladder after someone urinates, you start to worry about a potential cause of incomplete voiding or emptying. And individuals who have a longer urethra and a penis and a prostate, right? In those individuals, we may see BPH as a common cause of this, but there can also be things like neurogenic bladder or detrusor muscle underactivity that can also cause retained urine. But in this case, we don't see a large amount of retained urine here, so it seems like there's not urethral obstruction nor necessarily problems with incomplete voiding. It seems like the biggest culprit that we have here in terms of the abnormal stuff is the presence of blood on here. Promise, did you have any more info on whether or not it was like a few RBCs or a lot of RBCs on the microscopy? And if you don't have that, that's totally okay.
Let me see. Small amounts.
Small amounts. Okay.
And everything else is on the UA is normal.
Okay. So it seems like we have microscopic hematuria without pyuria. And then also in the setting of this frequent urination. I will be honest with everyone here. If we're getting into more advanced, think about more possible advanced causes of urinary frequency, particularly things that relate to urodynamics or pelvic floor dysfunction or some of the other elements or some of the other muscular elements of the lower urinary tract. That is, I would say, beyond my zone of comfort to even, I think, teach on in a way that it's likely to be accurate. So just to be authentic to that possibility, what I can do is say, how do we decide whether that is the zone that we're dealing with or something else that we may more often see. I think the finding of microscopic hematuria is something that can be challenging to contend with, particularly in the absence of pyuria. If you see those two things together, it's a very compatible explanation for cystitis, which with this urinary frequency we said is certainly possible. But in the absence of any sort of pyuria, no white cells, no leukocyte esterase, then I think we have to explore other potential causes of hematuria, right? Is there stones that are potentially there? Are there strictures or other potential underlying risk factors for malignancy in individuals who are post-menopausal, right? We also worry about this urine actually potentially not necessarily coming from the urinary tract itself, but actually coming from the vaginal cavity. And so any sort of, this would prompt me to go back and ask her more about any sort of spotting that she may have noticed. Sorry, we got a little announcement coming here. But if she's had any spotting, because that might move us into the world of post-menopausal bleeding, and certainly other pelvic anatomy abnormalities or changes could also irritate the bladder and lead to urinary frequency. So those would be some things that I would be thinking about here, right? Is there any post-menopausal bleeding that we haven't picked up yet on history? And if there's not, then think about if there's any signature of something like stones or other upper urinary tract problems that could cause this. And if that workup ends up not panning out, then I think looking more into some of the more muscular elements of the lower urinary tract that could cause frequent urination would probably be the path that I would take. But I say that with a heavy dose of humility, because again, we are several steps or several rings outside of a space that I commonly find myself in. So Promise, why don't you take us forward with kind of where things unfolded from here, and then we can learn together a little bit more about the final diagnosis and everything.
Yeah. Is it okay if I kind of just talk about the final
Yeah, of
diagnosis?
course.
Okay.
Please.
Okay. So the final diagnosis would be mixed incontinence. At this point, is pretty hard to differentiate between urgency or stress in terms of like, is it more stress predominant or is it urgency predominant? And then I can also go a little bit in depth into like the differences of all types of incontinence. And then the other issue, let's see. So there's one thing I forgot to mention on exam, is that she does have myofascial tenderness on the pelvic exam. And so with that, usually when you have myofascial tenderness, that's kind of what causes the incontinence. And myofascial tenderness, from what I learned, is like it doesn't really have any specific risk factors or anything. It's not something that you could prevent. Some people can be perfectly healthy and just suddenly develop myofascial tenderness. However, if someone has chronic low back pain, it's very likely that they could develop weak pelvic floor and therefore like myofascial tenderness, because with musculoskeletal, your low back pain will lead to your pelvic floor muscles kind of compensating. And so then they could develop a lot of these like pressure symptoms, incontinence, and even like defecation symptoms. And it's actually very common that I learned when I'm on Gyne. And then I would say like to tease out different types of incontinence, that's the main three types would be stress, which if they cough or have like some kind of movements and then urine leaks, then that would be a stress incontinence. Urge incontinence is when they have like a big sense of urgency, like they need to go. And then if they don't make it to the bathroom fast enough, then they leak. And that is caused by your detrusor muscle being overactive, like Jack, you talked about. For stress is actually more because of your urethra being hypermobile. So when you have weak pelvic floor muscle, a lot of intra-abdominal pressure, like she's obese, and then it could like push us down and then weakening what pelvic floor muscle, so your urethra can become easily moving and then your urine will leak. And then the last one is the overflow incontinence, which is why we did the post-Voigt trial. And that would be urinary retention, or it could be caused by like BPH, any kind of obstruction that leads to your bladder overflowing. And then Also, one other thing about urge incontinence is that for women who are postmenopausal, with the loss of, I think someone in the chat mentioned like a GU symptom of postmenopause. So actually, if they're postmenopausal with loss of estrogen, it leads to like losing the microflora in the urinary tract. And so the loss of that lactobacilli, which really maintains the acidity in the urinary tract, and then they like have estrogen also kind of like ensures there's enough collagen for the urogenital muscles, that whole bladder area. And so when you don't have that estrogen, you can lead to urge incontinence. And so like, I didn't know this until I'm on clinic, that vaginal estrogen is actually effective in treating urge incontinence, especially if it's postmenopausal woman. Yeah. Those are like the main teaching points. And then with regards to like the myofascial pain developed with like chronic low back pain, pelvic floor physical therapy would be really helpful.
Thank you so much, Promise. A tour de force of incontinence. That was absolutely incredible teaching. Thank you so much. And Nanda, I might, if you're okay with it, come back to you to share a little bit more. You put in, I think, a really helpful way also of thinking through the finding of postmenopausal bleeding in the chat, and would love to just elevate your teaching point there as well.
Sorry, I didn't know where the mic was. Can you hear me?
I can hear you great.
Okay. So yeah, there is this mnemonic for abnormal uterine bleeding. In this case of like hematuria, I think it's important to know if the patient has a history of smoking, considering like is one of the biggest cause of like bladder cancer. So this bleeding first has to be differentiated if it's coming from the bladder or the uterine. But for uterine bleeding, there is this mnemonic palm coin. So like palm, some people ask about this mnemonic. I don't know if everyone knows, but it would be like polyp, adenomyosis, leiomyoma, malignancies, and hyperplasia. So some of these causes are more common with like women premenopausal, but in this case for her, since she is already postmenopausal, malignancy would be one of cause of uterine bleeding. And then for the coin part of mnemonic would be like disorder with coagulation, ovulatory disorder being like polycystic ovary syndrome, one of them as well. Endometrial causes, iatrogenic, and others non-classified. The N is like not yet classified. So it's a nice way to think of it if you have a patient that comes with like uterine bleeding as well.
Amazing. Thank you so much, Nanda. We have, I mean, this is just, this is a special day. We have Promise delivering absolutely fire teaching point. We have Nanda bringing amazing teaching. Dominique, I wanted to say welcome. I saw in the chat that this is your first time, so welcome. And now we get to close it out with something that is even more exciting, which is going to be a summary of the teaching points from the one and only Jazz. Promise, thank you again for bringing this case. This was super educational, especially for me, and it seems like for so many others based off of how active the chat is. I just wanted to say thanks to everybody for bringing so much teaching, both verbally and in written format throughout this whole case. This was a blast.
Thank you so much.
Thanks. Thanks, everyone, and thanks, Jack. All right, so a lot to summarize here. So initially, we got the chief complaint of frequent urination, and that kind of had Jack to open with like a broad approach and kind of using an umbrella term here with like, is this an anatomical cause? So pipes and tubes was the words that he used, which was great. Or could this be solute, or is this a volume issue? So specifically, most common scenario would be dysuria or cystitis leading to irritation of the bladder, leading to the urge to urinate. Can also have problems with the detrusor muscle of the bladder, which can lead to incontinence, for example, like urge incontinence, and this is caused by an overactive detrusor muscle. Solutes would be the three main things, would be hyperglycemia, increased sodium intake, or medication such as mannitol. And then polydipsia would mean drinking more, either due to psychogenic etiologies or even something like DI, and DI would be further subclassified as nephrogenic versus central. And then Jack pointed out that the history that Promise gave us didn't really have any flavors of inflammation, diabetes, or excessive volume intake. Therefore, we should prioritize anatomy as the underlying etiology and should probably consider urodynamic studies. And another anatomical cause that the chat brought up was a possible cystocele, which is essentially a bulge of the bladder into the vagina, which can lead to urinary incontinence. When we all were equally confused of what post-supine test is, and we learned that it's when the patient lies on the bed and you ask them to cough, and it's pretty sensitive for diagnosing stress urinary incontinence. Individuals with longer urethra, both males and females, can be a risk factor for incomplete voiding and BPH in men. Microscopic hematuria, another pearl, was that this could be related to stones, stenosis, or mass of the GU tract. And in female patients, always ask about spotting to see if this could be coming from the uterus. So at that point, we got final diagnosis of mixed incontinence, and Promise shared a bunch of pearls, which I tried to capture here. One was chronic low back pain can lead to weakening of the pelvic floor muscles, leading to myofascial tenderness, which then can lead to incontinence. Urge incontinence is usually caused by, like we said earlier, detrusor muscle hyperactivity. Stress incontinence is usually the weakening of the pelvic floor muscles, which thereby mobility of the urethra. Overflow incontinence can lead due to weakening of the bladder muscles and not necessarily pelvic floor muscles. And then we learned that loss of estrogen in postmenopausal women can lead to urge incontinence, the loss of, so therefore replacing that estrogen can actually help in patients to have urge incontinence. And then something that I added, considering working in primary care, vaginal estrogen is actually pretty effective in women that are postmenopausal and have recurrent UTIs. Rather than giving them chronic antibiotics, vaginal estrogen is safe and can actually significantly reduce their recurrent urinary tract infections. And then we learned further that uterine bleeding it has a great mnemonic called POM-COIN, which stands for polyp, adenomyosis, leiomyoma, and malignancy. In the second half of it, coagulopathy, ovulatory etiologies, endometrial etiologies, iatrogenic, or not otherwise classified. The end.
Amazing. Thank you so much, Jazz. This is phenomenal. I think in one thing that I was also reflecting on with cases like this is just like how much nuance there is to so many of these chief concerns that come up in the primary care and in the ambulatory setting. You know, Promise, like you were sharing that this is a case that was all handled within a clinic visit, and I think it just heightens the respect that I have for primary care providers out there who are able, or anyone who practices in the ambulatory setting, because there is such enormous progress that can be made, and oftentimes under-resourced and time constrained environments. And I think, Promise, the nuance of the teaching points that you shared really highlights that. So thanks everybody so much for a really fun Wednesday VMR. And Bettina, thank you for the incredible scribing. It is a delight to have you here, and I'm so happy that you were able to make it. And have a great week, everybody. We'll see you later.